Hello, my name is Day Jones, and this is a correlational research review of the study Rethinking 30-Day Admission Rates. Shorter intervals might be better indicators of quality of care. This study was done by Chin, Bang, McAnam, and Romano, and is published on October 2016. Currently, hospital readmission rate reduction is a national public policy issue. The federal government and insurance companies require acute care hospitals to report the 30-day admission rate as a quality of care measure between hospitals. Unfortunately, this 30-day interval is problematic. 30 days is not supported by sufficient empirical evidence. The ACA authorized CMS to create the Hospital Readmission Reduction Program, which developed methods for measuring readmission to hospitals for all causes and unplanned cases for public reporting. As a result, hospitals with excessive rates of readmissions are penalized. These measures operate under certain assumptions of hospitals' responsibilities post-discharge. They were also endorsed by the National Quality Forum. Assumption 1. Hospital readmissions are heavily influenced by hospital practices. Assumption 2. CMS reports that outcomes occurring within 30 days can be influenced by hospital care and the early transition to the outpatient setting. Assumption 3. Post-discharge care coordination is in their purview, regardless of financial or quality impacts for all 30 days. And Assumption 4. Hospitals can affect such a level of care for that length of time. For the purposes of this study, they would like to establish whether the CMS model is actually accurate. It's crucial to statistically establish the length of time that the hospital can effectively influence the rate of unplanned readmission to conserve resources. Adjustments for demographic and geographical factors would increase the accuracy of public reporting. This study was designed to examine the relationship between unplanned readmission risk factors as relates to hospital and non-hospital resources. An accurate depiction of hospital effect would allow better problem solving of external factors in the plan of care. The study could potentially identify the amount of time post-discharge that hospitals can affect the most change by increased monitoring based upon data for differing conditions. The research questions that were asked: 1. Does hospital attribution of unplanned readmission differ based on condition? 2. Is there an optimal time frame for hospital attributable readmission? And 3. Do CMS risk adjustment models account for factors outside of hospital factors? For the conceptual framework of this study, they used hierarchical models as a baseline. Statistical method was ICC, or intra-cluster correlation coefficient, It measures relatedness or similarity of data, and it's denoted by the symbol rho, which looks like a P. Now, calculating ICC compares the variance between clusters with the variance within clusters. And you can see the equation, or a simplified version, just below. This study is guided by hierarchical models that account for patient characteristics and separate risk of readmission associated with hospitals from that of non-hospital sources. Rho is a measure of the variance between clusters compared with that of clusters within data. It ranges from 0 to 1. As the ICC increases, the more the individuals in the study resemble one another. This means that if readmissions were heavily reliant on hospitals, the ICC should be large or close to 1. If outside sources had a higher influence, then the ICC should be small. Researchers calculated the ICC for different conditions and discharge intervals while accounting for patient-level clinical factors. Now our methods. This study used a cohort study. It was through a database using 4 states, adapted course source code, an all-payer data set, 1 to 90 days from the index discharge from that database, and then statistics and baseline rates for all of the analyses. Using databases from the Healthcare Cost and Utilization Project, an all-payer data set from 2005 to 2011 for Arizona, New York, California, and Florida was constructed using Yale School of Medicine's CORE, or Center for Outcomes Research and Evaluation, source code for measuring risk standardized readmission rates. They created 3 encounter-based cohorts for acute myocardial infarction, heart failure, and pneumonia, and in addition, 5 mutually exclusive cohorts for medicine, surgery and gynecology, cardiorespiratory, cardiovascular, and neurology patients. Inclusion required that the patient was discharged alive at age 65 or older. All others were excluded from the study through the data collection. The data was collected from the databases by adapting the core source code to collect every 90 days from the index discharge date for the selected patients. These patients were all-cause, unplanned readmission patients within the required criteria. Researchers established baselines of the cohort summary statistics and readmission rates using previous logistic regression models. They then adjusted the data collected from each cohort for age, principal diagnosis, age, and clinical factors. Calculating the ICC for each post-discharge interval gave them the comparative variance between hospitals' risk of readmission as well as risk from non-hospital sources. Lastly, they did a stratified analysis of the ICCs of 7 and 30-day readmissions for comparison, along with the performance changes during those same periods of time that the hospitals involved. Sample size was a little over 15 million, 6.7 of which were patients at 910 hospitals. 56.5% were female. Median age was 78, with an interquartile range of 71 to 84. 71.7% of the patients were white, and 89.7% had a primary payer of Medicare. Unplanned readmissions accounted for 90.1% of all-cause readmissions. The observed 30-day unplanned readmission rate was 17.5% for AMIs, 23.6% for heart failure, and 17.6% for pneumonia. That's 15.5% for the hospital-wide all-cause unplanned readmissions. The other cohorts were 11.3% for surgery and gynecology, 20.6% for cardiorespiratory and cardiovascular, and 13.7% for neurology. The researchers found that zip codes in the lowest household income quartile had higher 30-day readmission risk, 1.1 relative to the highest household income quartile in all groups. In rural counties, compared to larger urban communities, they experienced at least a 41% greater 30-day readmission risk. Now, the ICC for all 3 specific medical conditions, that would be acute myocardial infarction, heart failure, and pneumonia, dropped rapidly. That'd be from 2.7, 3.2, 2.7, 1.6, and 3.2 to less than 1% by day 4, reaching a minimum of 0.8% or less at 7 days after discharge. The ICC dissipated by the 7th day after discharge, decreasing between the 1st and the 7th day by 78%, 49%, and 76% among patients admitted with acute myocardial infarction, heart failure, and pneumonia, respectively. Now, ICC estimates at specific readmission 10th day, hospital level variation rose slightly but steadily in the base models for risk standardized in hospital-wide readmissions at the 30th day and at the 90th day. But hospital level variation did not rise much at all between the 10th and 90th days in the 8 models. That's all 8 models. When they compared 7 to 30-day readmissions, the median change was less than 0.3%. As a baseline, there was a weak correlation between the hospital level median length of stay and readmission rate. And it was found only on the post-discharge day of the cardiovascular cohort on the first day, and R was equal to negative 0.08. There was no significant relationship with the other cohorts. Readmission rates were first used by the Department of Veterans Affairs in 1953, and it was used to calculate neuropsychiatric patients' risk of return. In 2010 was the first time that CMS brought it back into the industry with the Hospital Risk Reduction Program under the ACA. Studies have previously evaluated the interval for readmission rates used as a quality measure, but they've never evaluated the 30-day interval in the exact same way that this study did. It's always been study limitations. The 4 states may not be representative of the entire U.S., and that's based upon the data that they used. That data also predates the high-risk reduction program. Identifiers were state-specific, so readmission rates could have been understated. They could not include out-of-state readmissions. Hospital quality is also complicated, and ICC may not be sufficient to capture hospital quality as a data element for studying on its own. A single metric may be insufficient for measuring it. Now, the conclusions that were reached by this study are that hospital effect is, as far as care plans are concerned, and post-discharge patient interaction is strongest 7 days after discharge. After 7 days, economic and geographic factors become greater influences on hospital readmission, or at least unplanned. 30 days is appropriate for improving hospital care quality. That is only if the goal of CMS using it, the 30-day interval, is to make hospitals improve their care quality in that time frame. If it's not, if the goal is to actually publicly report hospital recommendations for patients looking to treat their conditions at the best possible facility, then 7 days is more appropriate, according to this study. As far as recommendations are concerned, direct quote from the study says that future research and policy discussions should consider shared attribution of readmissions, especially after 5 to 7 days, among post-discharge care providers such as skilled nursing facilities, dialysis facilities, and primary care providers. And I do agree with that. It seems that this study, even if it did have its flaws, did point to 5 to 7 days being a much more accurate indicator of quality improvement, and essentially the next step should be looking to other providers to see if there can be more data added to that conclusion. With that, there are the references. This study is from the Health Affairs Project HOPE, October 2016. And with that, I will conclude this recording. Thank you. My name is Day Jones. Have a great day.